Welcome to this special webinar event presented by the SAB, Novel Coronavirus COVID-19 Clinical Insights and Updates, part of our 2020 monthly educational webinar series. Before we get started, a few housekeeping items. You have joined in the listen-only mode. Please ask questions throughout using the question feature. We will address them during and after Dr. Weber's lecture. Any we do not get to will be answered by email after the webinar. Dr. Pritchett is our SAB president and he will be our moderator this evening. Dr. Pritchett is an advanced bronchoscopist who is board certified in internal medicine, pulmonary disease, and critical care medicine. He also has a master's degree in public health. He serves as the director of the Chest Center of the Carolinas at First Health Hospital System in Pinehurst, North Carolina. He's a private practice physician with Pinehurst Medical Clinic for more than 10 years. Dr. Pritchett?
Thanks, Emily, and I wanted to welcome everybody to this special webinar that SAB's having for you tonight. So we're branching out a little bit from our regular comfort zone of strictly bronchoscopy-related topics, but this is a universal topic that's obviously touched every single one of you in here in some way or another, including maybe even causing a little panic. So the webinar tonight is really to help, kind of put that into perspective, separate facts from fiction, give everybody some good information. Some of this certainly will be with respect to bronchoscopy, but I think the vast majority of this is really general education and will be applicable to everybody from ICU nurses to bronchoscopists and ICU doctors and infectious disease specialists and really the general public. So I wanted to introduce our speaker. We're very excited to have Dr. Stephen Weber, who's an infectious disease specialist and epidemiologist at the University of Chicago Medicine. His clinical and research interests focus on the management and control of multi-drug resistant pathogens in hospitalized patients. He's deeply involved in infection prevention policy and served as chair of the Society of Healthcare Epidemiology of America's Public Policy Committee for almost 10 years. He was chief healthcare epidemiologist at the University of Chicago for a decade, during which he led institutional and regional responses to outbreaks such as SARS, Ebola, and pandemic influenza. Dr. Weber now serves as Chief Medical Officer and Senior Vice President for Clinical Excellence at the University of Chicago Medicine. In this role, he oversees clinical practice, policy, quality, and safety. He co-leads the health system's hospital incident command structure, which is responsible for the response of the ongoing COVID-19 pandemic. Therefore, I can't think of a better person to offer this webinar, and we thank him. Without further ado, Dr. Weber, the floor is yours.
All right, thanks very much, Michael, and thanks everyone for inviting me and for joining this evening. Let me get the screen set up for us. I'm reminded about now 20 years almost or so ago, at the time of SARS and bioterror concerns in the US, that there was a New Yorker magazine cartoon of two socialites at a cocktail party, and one remarking to the other, "How typically brilliant of you to have invited an epidemiologist." So I'm grateful to see that my discipline has become, at least for a moment in time, interesting and cool to my colleagues and others. So thank you very much for having me. A light start to obviously a very serious subject. And over the next bit of time, and I'm hoping we can keep this in such a way that we leave plenty of time for questions. I have the question box and prompt open here, so if there are questions as we go through, we'll be mindful of that to try to give responses in real time. But to really go through and just give you an overview of the pandemic as it's unfolded, really a lot of options about how we want to approach this and what we want to focus on. So what you see in front of you now are the areas of focus that I intend to discuss. We can go deep on any number of these. My disclosures, I do need to acknowledge that I do have stock equity in Gilead, and as we'll discuss later on, they do have a drug product which may have activity in the epidemic. But I have a couple of other important disclosures. One is, as Michael said in the introduction, that I am intimately involved with our health system and regional preparedness. So I'll be the first to confess. I usually spend more time on my slides, and frankly, the slides have needed to be updated about every half hour. So we'll work through that together, I think. The second piece to acknowledge is that any bit of evidence that you see over the next hour or plus is the product of, at best, a single institution case series or report, and at worst is consensus opinion that is changing every day. This is a disease and an entity that is essentially 3 to 4 months old. And so I think as colleagues here on the call will forgive one another, but also it gives us all a chance to really exchange not only from what we've read about in this growing literature, but also I suspect for some on the call across the country and around the world, maybe some personal experience in tapping into this. So why don't we go ahead and we'll get started. And epidemics all start with an origin story. And in this case, this is an epidemic that arose, we believe, in the area of Wuhan, China. Wuhan is a huge city landlocked city in the Hubei province in central China. Wuhan is a place that's near and dear to many of us at the University of Chicago. We have a number of educational affiliations with Wuhan. I've traveled there on a number of occasions and really got to know a lot of the clinicians there in my field. And so that's given us a window of insight to the experience over the last several months, which has been remarkable. Their first report came out at the very end of December of around 40, mostly men, who had presented with an aggressive and progressive viral pneumonia. These were folks who had tested negative, both invasively and otherwise, for influenza and common respiratory pathogens. Noted again, as I said, a predominance among men, and a real stark increase in the risk of complications and mortality around older patients. Early on, there was a lot made of the exposure of the first series of patients to the Wuhan wet market. And wet markets are really just open markets where there's fresh food, fresh seafood, fresh meat and whatnot, as opposed to a dry goods or dry market. I do want to get out there straight away and say some of that thinking is still evolved. And I think when the dust finally does settle from the pandemic, there'll be a lot more insight gained about this beginning, but one needs to take with more than a grain of salt, not only those kinds of associations, but particularly so, as a lot of you can appreciate, some of the, honestly, thinly tinged racism around issues about cultural practices, most or many of them absolutely factitious, and to that end, really just casting this in a very negative way, which continues through in some segments to today. In part to that, one of the conventions that's been adopted in public health is to ensure that we are not 100 years later referring to something as the Spanish flu, as is the case with the 1918 epidemic, instead to adopt a more rigorous naming convention. And in this case, as more was learned about the virus, this was a coronavirus that very similar in structure and behavior to the severe acute respiratory syndrome virus that we know from a decade or more ago. So it achieved the designation SARS coronavirus 2. And then at the time, a name that a lot of us said, well, that will never stick, of COVID-19, coronavirus disease 2019. And that is obviously now an all too familiar term, not only for an expert audience like this, but for lay individuals and really across the US and across society. The experience in China giving way to the pandemic that's now we're experiencing is really remarkable and something we'll keep coming back to. And there's a lot to be said and examined about the experience of public health management that's cultural, in some cases societal, some cases governmental, and one can adopt a variety of either even cynical or at times suspicious considerations when we look to the point of origin of an epidemic. And this is not unique to China. The same might be said when we see epidemics that have arisen in other parts of the world, but still there's been a lot of hesitation. In a lot of parts of the world, there was I think really a sense of disbelief or confusion about what was actually happening in China. The fact is that for those of us, and again, I suspect there are folks who are participating in the webinar tonight who either themselves are in that region of the world or who have close contacts, as I do, in that part of the world, what we saw in the news, I think, really scratched the surface. The approach in China was a really aggressive containment strategy, which could be framed as saying that the Hubei province in which Wuhan sits really became, I say this with great pause, but was in essence to sacrifice, say this was the area where containment would be set up. This was where the Chinese government and public health officials would fight the battle, very aggressive, and by many measures, in some cases acknowledged by the World Health Organization, relatively effective in containing to that region. The hazards that came with the approach of containment in and around that region really come in our understanding of the epidemiology of the infection. And I'll come back to that later on, but we'll start because it's the same analogy that'll hold whether you're talking about a large province in a major city in China or a nursing home in the US Pacific Northwest, which is to say a function of containment like that will have the dual effect of increasing within that contained area infectivity. And we did see an enormously high transmission rate in Hubei and in Wuhan. That may have been a function of that containment. Our colleague who was working in a fever clinic in downtown Wuhan, at one point, about 60 to 70% of the patients presenting were testing positive for coronavirus, this over a period of 2 months. So again, that's not going to happen naturally in an epidemic, but with a closed population, you will see that happen. The second piece that can happen that we do believe happened in China and specifically in Hubei and Wuhan was with that concentration of cases, high number of cases, short period of time, is a complete exhaustion of a healthcare system. Let me just put a word in for our colleagues who practice in Wuhan and the healthcare resources in Wuhan. For folks who haven't been to that part of the world, this is not some backwoods, under-resourced area. There is an array of healthcare facilities and options, as there are probably in all of our cities and locations. Everything from the most state-of-the-art critical care to single practices and whatnot. But the fundamental issue is to say that we can't project onto that these were folks who didn't know what they were doing. This is an incredibly talented and resourced group of clinicians who sacrificed a lot, but were so overwhelmed that it's reasonable to think that the mortality rate locally may have been higher than what we might have seen with a more dispersed, either geographically or temporally, epidemic. So then we go forward to the rest of the world. And I say pandemic finally because there was a lot of angsting in the lay press and maybe among our colleagues about when will the World Health Organization declare it a pandemic. For a lot of us within the field, it almost doesn't matter. There's no magic that comes with that. The definition of pandemic is really multiple epidemics or ongoing epidemics in multiple widespread geographic regions, continents often used. And by an informal definition, we've been at that long before the World Health Organization called this out in the last couple of days. But for what it's worth, the pandemic is declared. The data that you see here in terms of the deaths and the number infected are through last night. They are no longer up to date. So by way of example, the United States now up above 1,500 infected and 40 deaths. Italy is now at 15,000 infections. But there are some interesting lessons in here. We know that China at this point, with that concentration in Hubei province, are seeing many, many fewer cases arising on a daily basis. In some ways, the phenomenon may not be around a new therapy or a new approach, but quite literally, as the mathematical modeling of these kinds of pandemics show, is in those highly affected regions, they have probably just exhausted the supply of susceptible patients and susceptible population. And once you reach that point, there's no one else really to transmit it to. The people who will get sick and die have gotten sick and died. But then some interesting stories as we go out from there. Iran, Italy, which has really been resonated with, I think, a lot of folks in the United States, by both a cultural, in some cases familial or genealogical association. The experience there, again, and continue worsening from day to day, despite progressively more intensive social distancing strategies. They're down to the point now where the only businesses that are open are grocery stores and pharmacies. But the case count is still rising. I'd point out that even with those measures, the consequences we see now, the case count that continues to rise in a dramatic way each day in Italy, is not a product or a failure of what's been done in the last 2 days, but is a reflection of the public health measures several days ago. The graph at the bottom is a trending of the case counts. And I have to tell you, I believe this is the United States. But it doesn't matter, because in almost every single jurisdiction, every single municipality, every single nation which has been affected, this is what the curve looks like. And you can superimpose the American curve on the Italian curve, on the early Chinese curve, and they all look the same. And so each day I wake up, we in epidemiology will all have our favorite tracker to look at these cases. I happen to be heretical and not falling in love with the Johns Hopkins resource. And as a consequence of that, I can go in and give you a pretty good estimate about what's going to happen tomorrow in Germany or in Spain or now in the United States. And those are tracking very, very predictably. What becomes interesting as we get into the control conversations a little bit later on is how can you attenuate? How can you change the shape of those curves down the road? How do you prevent the peak from reaching an abysmal level as we saw in, as we're seeing in Italy and some other locations? When we look at that here, I'll draw out again and mention again South Korea. I apologize for the typo there. South Korea is a really interesting story, a place where they were on that very sharp curve, but have not accumulated the mortality that we've seen in many other countries. We'll come back to that as we talk about testing, and for good reason. With the it's hardly a controversy, but with the frustration around testing resources in the United States, at least, South Korea is rightly held up as an example of the benefits of aggressive and widespread testing. And again, we'll come back to that in just a moment. So what does this infection look like? And this is, again, it's unsatisfying and too general in many ways, but it's also an honest assessment of where we stand with a 3 or 4 month old disease. COVID-19 presents innocuously enough with cough and fever at very high frequency of patients. What starts to distinguish those who become sicker is the progression of dyspnea. So again, those individuals who do not develop that sense of dyspnea, that restriction on the breathing, they're the folks who tend to get better over time. We'll come back to the course of the illness in a moment. There's a lot of variation in terms of non-respiratory, non-pulmonary symptoms. Certainly a lot of headaches, abdominal pain, nausea, vomiting are variable. There are places where they're feeling very confident about using symptoms such as nasal congestion, rhinorrhea, and whatnot as exculpatory to the risk of it being COVID-19. You know, I don't feel really confident about that as this disease, if it's crested in your area, or if it's coming to your area, I wouldn't feel good using that to exonerate someone from infection prevention or quarantine. But it is notable that both in China and now increasingly in Western Europe, they're highlighting that the folks who are coming in with a sense of congestion, runny nose and whatnot tend not to be those who end up with COVID-19. But what does this look like? Here, you know, there's a graph at the bottom in terms of the ultimate progression. The incubation period is getting drilled down with more and more refinement, seems to be settling out at around 5.1 days or so. The spread on that, you'll see people who are a little bit earlier, you'll see some laggards, but that's a pretty reasonable estimate where we stand. The period of contagiousness is obviously essential to not only clinicians, but to epidemiologists for sure. You know, this is the variable that in many ways drives the scope and span of an epidemic, the intersection of the period in which someone's infected and the extent to which that period includes times when the individual is not particularly symptomatic. And in this case, that's definitely the problem and a real issue, in that folks seem to be symptomatic before the onset, certainly the onset of dramatic symptoms. They linger in contagiousness for a median, again, of around 11 days. There's some extension beyond that, but this is important when we get into control strategies, because the notion of keeping people in quarantine for 2 weeks or 2.5 weeks seems to be acceptable. Will you miss an individual from time to time who's a longer-term shedder? Potentially. Will maneuvers that folks like us might try in terms of immune modulatory or anti-inflammatory medications, might that extend the course of shedding? We'll come back to that later on. But fundamentally, this is a good set of numbers based on the experience, again, largely in Asia and Europe, and beginning now in the US, around that contagiousness and incubation. The degree of contagiousness is a wonky little piece that comes from the epidemiology world. This is the so-called R0 that you see there. And for those who aren't as familiar with that, R0 is really a mathematical representation of the number of other individuals who become ill, or at least to whom the pathogen is transmitted from an index patient or case. So in this example, we would say at this time, unchecked in the epidemic, when you're on that high slope of the curve, one person with COVID-19 is apt to transmit it to just over 2 other people. There's a range of disease states and pathogens that have comparable R0s. We see measles has a very high number, smallpox an even higher number. More of the common infections that we see will be around 1.5, 2. The reason why this number is important to epidemiologists is that when we model infectious diseases and we model infectious disease control, the entire aim is to get the R0 value to be 1 or less. And that makes sense when you just step back from it. The idea of if I'm sick, if I get 1 person or fewer sick, then you have an epidemic that's going to extinguish over time. And that becomes a critical value when we're trying to model our interventions. Look, the money value on this for all of us as clinicians, as citizens, as family members, and as just worried folks in general is the mortality number. And my gosh, this has been hard to pin down. But look at the pie graph first. This is really the breakdown now, synthesizing everything else that's on the slide here. Let's start with a hypothetical pool of 100 patients, 100 individuals who are infected with COVID-19. To the best evidence and experience we have to date, and this has been consistent in China, in Milan, now in Germany and Spain, is about 75 or 80 of those folks will have a relatively innocuous respiratory symptoms, some malaise, some body aches, some fever, as we said earlier, but they will recover. This is what we hope for when you hear about, that Tom Hanks is sick, the basketball players in the US who are testing positive and say, well, I feel pretty good. They're right. They're likely, and we hope, going to end up in the 80%. The trouble is that consistently, wherever this epidemic has struck, we've seen the other 20%. And that 20% of patients are those who are coming to need hospitalization, usually by the evolution of progressive dyspnea and oxygen requirement about 7 days after the onset of symptoms. So this is the phenomenon that people have described on social media and elsewhere of somebody who's diagnosed, or maybe they're at home caring for themselves, and then they're getting progressively more short of breath. There was just a lay press article today about somebody who's hospitalized in New Jersey, this young guy who's tweeting out to folks and saying, my breathing's getting harder, they think I might need to be intubated tomorrow. So it's the scenario in which 80% doing okay, 20% coming to the hospital after this progressive dyspnea. But that's when it gets really, really dicey, because of that 20% that comes into the hospital, in most places where it's looked at, it's anywhere from 30 to 50 to +% that are ending up in the ICU. So that's the number that I think as healthcare providers, in my case, and kind of health system administrators, that's the number that gets alarming. Because if I told you we would just see a world in which, Americans or wherever you might be from, that 80% of the people got sick would be fine, that's okay. That's the naysayers who say this is nothing more than a common cold. Well, they're right for that 80%. For the other 20%, it's more than a common cold. And within that group, there's a really substantial risk of you progressing to needing ICU care, needing ventilatory support. And that's the group from whom the roughly 1 to 2 to 3% mortality accumulates. That's a big number, 1 to 2%. And we'll come back to it in just a moment, but the 1 to 2%, and Michael and I were talking about this a little bit beforehand, when really examined rigorously, and this is hard because we don't routinely test everybody for influenza, but best estimates of mortality, straight up mortality of influenza, is around 0.1, 0.15%. So when you see Tony Fauci from the US National Institute of Allergy and Infectious Disease saying that this disease has upwards of 10 to 20%, 20 times increased mortality, that's accurate. That's a big number. I can't stress it enough. It's easy to sit on talk radio and say 98% of people get fine, 2% of people dying. To put it in perspective, the best estimates around the 1918, sorry Spaniards, Spanish flu was actually 2.5%. So this is a really big number. The differences in those diseases relate to the individuals who were struck, because thus far in China and in Europe, the individuals who are making up that proportion of folks hospitalized, they are folks who are older consistently. That's very much unlike the 1918 pandemic. The median age of those who are hospitalized so far is around 60. The median age of those who die is about 80. So that is different than the concerns with pandemic flu. It is a disease that absolutely skews towards older individuals. The phenomenon around children is a little bit harder to dissect out. We see absolutely fewer severe cases in children. That doesn't mean there are none. It's one of the messaging points that I think has come out well in some of the US reporting and from public health officials here, which is to say that when we say there's an extremely low risk to children, it doesn't mean that we won't hear about a younger child who becomes severely ill, and even in some places to see younger children, adolescents who've actually died. But that number is really very, very small. It is a near linear association once you get beyond the age of 30 or 40 between the risk of mortality and age. And so that's becomes a really critical dynamic. Now, you guys are all clinicians and diagnosticians, so let's get into kind of the meat of this and how we think about the practice. You know, the first most important test in terms of looking at a potential case of COVID-19 is a negative influenza assay. And by this, I prefer a respiratory viral panel or dedicated non-rapid testing. Now, all the experienced clinicians on the line will appreciate and say, wait, if you're going to say that a positive flu or RVP excludes COVID-19, then you're saying that there can't be co-infections. It's too early in a 4-month-old disease to say that, but from a practical standpoint, that's been a useful a surrogate right now as we're trying to determine in places where tests are in short supply. And to this, I'm speaking largely only to our American listeners. But in that group, the fact is that a flu positive or another common respiratory pathogen positive can be used to really reduce your pretest probability that this will end up being coronavirus COVID-19. The most common assay that's been applied and the one that has been embraced by the US CDC is a real-time PCR. So this is, as many of you know, in essence, a semi-quantitative method where you can really try to do comparisons and sensitivity between different diagnostic modalities by looking, for example, at about cycle times to positivity. So in many cases, an effective methodology in terms of disease and pathogen detection. The hazard with this is that it is, as we've seen in the US, sometimes hard to bring these to scale. There are issues about reagents now in DNA, or in this case, RNA extraction. And so people are looking for more robust and durable testing that can be brought out to the field more easily. There's a big move and a lot of examination around serological testing. At the University of Chicago, we have a number of investigators really digging deep on this, and certainly the Chinese, who have an unwelcome head start from their perspective in looking at this, have really already test-driven a number of serological assays. For right now, for the most part, I'd characterize those as not ready for prime time, in part because we're looking for rapid, meaning early diagnostics. So the RT-PCR is still the mainstay of this. Now, let me say a little bit about just some peculiarities in terms of the US experience. And again, this gets into a degree of politics, but frankly, I think there ought to be a bipartisan conclusion that the management and the availability of testing in this country has been absolutely abysmal and shameful. So to that end, to the extent that the supply line in terms of getting testing through public health resources in the United States has been really, really crippled. And I speak to you from Illinois, where there's a really robust state lab. We were one of the first 6 states that had coronavirus testing, and it's still been miserable to get done. I've been grateful to see not only the innovation led at places like University of Washington and others that have really developed by force of need their own independent testing, but they're now coming online with a number of commercial labs that have tests that are out there. The CDC has kind of gone back to say that not all these tests will be cross-validated. I understand that at some level, but in a world where we're trying to make diagnostic determination, where we're trying to rule people in or out and make serious decisions about quarantine, make serious decisions about lifestyle, we need some test. And so I'm grateful to see that a number of firms, including Viracor, LabCorp, Quest, and others are coming online. The test availability, I said, it has been hazardous in the US, beyond hazardous. The performance has been very interesting with the RT-PCR, and I know, I suspect at least this is an issue for many of you in your field, because the reality is that to assess the performance of any of these tests is fraught with challenge, in part because there is no gold standard. We cannot determine and quantify sensitivity and specificity absent a gold standard. And so to that end, we get into a lot of issues around decision science, a lot of issues around discriminant testing, and all these things that we'd like for clinicians to not have to think about. But fundamentally, what we observed is that the tests can be falsely negative early in the course of infection. We know that issues about handling of the RNA, it seems that if the samples are refrigerated, there may be some degradation in the RNA, and that might have accounted, these two phenomena, for these reports that I think many of us have seen of patient tested positive, patient tested negative, then positive again. That probably has more to say about the performance of the tests and the conduct of the tests than it does something esoteric and magical about this disease, but it has made it really challenging. Now, there's an embedded thing in the diagnostic testing that I just said that becomes relevant to what a lot of us are seeing in the lay press and a lot of what's driving demand at a number of our facilities, which is to say, and I suspect folks on the line have heard this from patients or family members or friends, I think I was exposed to COVID-19, I want to be tested. This is fundamentally flawed, not on the basis of the test, not on the basis of public health, but fundamentally, somebody who is not sick with COVID-19 is not going to test positive. There's no reason to test them. So I understand, and maybe we'll talk in questions about, look, with the whole thing in the US with the National Basketball Association, the NBA, frankly, I'm grateful for the light this has shown on the seriousness of this pandemic. But on the other hand, the prospect that was reported yesterday that now all NBA players need to be tested is ludicrous and is redirecting tests away from people who need them, including many of you on the line who are going to be seeing seriously ill patients. There's another dynamic about testing strategies that is really relevant and that folks in the US have been focusing on a lot, which is testing density. So I'm referring to nothing more here than how much testing are you doing in a population? Because reasonably speaking, if you have a rational approach to testing, if you have fewer tests, you're going to do them on the sickest people, the hospitalized folks, the folks who you might be contemplating for bronchoscopy. In that kind of phenomenon, you're going to see a higher mortality among those who are tested. That stands to reason. There's nothing magical or tough math there. If you're testing a broader population, you will see a decreased incidence of disease, but also decreased mortality. So in my NBA example, if you test the entire NBA, all of whom are asymptomatic, and one or two of them palpa positive for reasons we can't explain, I'm guessing and hoping for their sake that the mortality will be zero. However, if you're doing what we're doing now in some regions, is just testing the sickest of the sick, we're going to see a higher number. So this plays out in trying to understand the overall scope of the pandemic. So go back to what I said earlier. How do we think about what was going on in Wuhan? Well, it's hard to know. Closed population, overwhelmed local resources. Now extend that and try to compare mortality rates in a place like South Korea, where they're testing appropriately, maybe sometimes inappropriately, but doing it like crazy. To put it in perspective, the number of tests per million population in South Korea right now is somewhere around 24 to 2,500, okay? If we were in a room together, I'd ask for an estimate about what that same number is in the United States, and whomever said 4 or 5 would be right. So you could look at that and say that, let's say South Korea had it exactly right, well then their 0.9 or 0.8% mortality is maybe spot on. In the United States, where we're going to start seeing those numbers come up, maybe we're overestimating the mortality. So it is still hard to know, and that's why on that slide about mortality, without apology, I talk about a range from 1 to 3%. What about imaging? So in both imaging and when we come on to talk about the bronchoscopy or different means of more invasive sampling, the imaging is sort of leads in terms of some of the challenges that we face, because in each of the studies that you do with a highly infectious and potentially lethal disease, you need to balance the yield of the test with the risk to the operator, to the patient, and so on. So in the case of CT exams, as the Chinese were really honing their testing to apply, their microbiologic testing to apply to the disease, they came to rely on these rapid CT scans. These were 16 cut chest CTs. And what they found is that they were seeing some characteristic early ground glass changes on the CTs that actually antedated laboratory positivity. And this got a lot of play in the field, and as the pandemic started to spread, folks have tended to walk that back right now, and there's been a little less reliance on the CT scans. I have to say, as we're trying to digest all this new information, a couple of the radiographic societies came out and said, we don't think that and I'm obviously paraphrasing, I don't want to editorialize too much, but it's just acknowledging where we're at in the pandemic, that in from their perspective, from the radiology societies, it was to say the data from China we don't yet find compelling, and so for now don't get CTs on these folks. Again, forgive me for sort of provocatively stating that, but the truth is that we still don't really know the role of the CT exam, and so I don't agree with a statement from a professional society saying there's no use to this, it shouldn't be done. Rather, I think the more appropriate framing is to acknowledge that until we know more, in as much as CT scanning all these folks, especially in an epidemic or pandemic setting, is going to hazard a risk of cross-transmission from cleaning the machine, hazard a risk of transporting patients, hazard a risk of the technicians and others who are contacting the patient, I think on balance, that's the position that we're adopting. I think a lot of peer institutions are. If you need a CT for clinical care, get a CT scan. But in terms of the idea of, as we contemplated, contracting, having a van with a 16-slice CT scanner in it, there seems to be better ways you can spend your money in managing the pandemic. But of course, all that is a prelude to those of you who are expert at collecting robust microbiologic sampling. The NP aspirate remains the mainstay of diagnosis right now. There's been some really interesting literature in the most recent days, and I appreciate Gus and others for sharing some of this with me, showing maybe a slight advantage for bronchoscopy versus mini BAL over the NP aspirate. What I've done in the notes here around sampling considerations is to give a little editorialization in italics, which is to say, I think it's early to conclude from any one study, even when robustly done, to say that the bronch is necessarily better than the NP aspirate or the role of BAL. I think that will be clarified. Unfortunately, we're going to get a lot of time, experience with this epidemic and with different viruses as we go forward. But for right now, I think that difference is relatively trivial. And just forgive me if for just framing it that way. What becomes really compelling is the effect on management of going for more invasive sampling. And in a world where right now we have not lined up fully around the most appropriate or even most effective therapies, one can make the case, and it is being made, that the effect on management of doing confirmatory testing with bronchoscopy or mini BAL is really minimal. The NP aspirate will give you the information that you need, and then I want to come back to another thought on that, and so you're not adding it. And so the last piece is, what's the risk to the patient and providers? And obviously for the 95 people on the line right now, the risk to your patients is of course minimal because of your expertise and the great care and safety that you provide all of your studies with. That being said, to providers, staff in the room, and others, this is an aerosol generating procedure, and so therefore is increasing your own risk and that of your teammates of transmission. So when I weigh out from an epidemiologist and infectious disease specialist standpoint, a more invasive testing that is perhaps only trivially more sensitive than less invasive testing, the results of which may be somewhat minimal in terms of the impact on management, and the risk to my colleagues, in this case you all, and others, I weigh in on the bronchoscopy is not part of my default setting and recommendation in terms of working for these patients. And I think that's where consensus is forming around this. Now, that's not to say these individuals would never be suitable for bronchoscopy. There may be issues as we start seeing more populations of immunocompromised patients. Perhaps that risk of dual diagnosis becomes more prevalent. And so we need to make the invasive interrogation to find out if there is a fungal pathogen or a resistant bacterial pathogen. Or perhaps what we'll find is that we need to do this for other alternative diagnosis or complications or superinfections. The piece that I'm really having a hard time with, because we're hearing reports of this from Italy and elsewhere, of getting into this notion of doing repeated invasive testing in order to resample whether to confirm the diagnosis, assess the progress of infection, or to absolutely confirm that a patient does not have coronavirus and COVID-19 infection. For me, at this stage, I think that's a flawed approach, because not of the hazards of bronchoscopy or the skills of the bronchoscopist, but rather because the challenges of the laboratory testing. We already know that even with good sampling, there's going to be irregularities in terms of viral shedding, there's going to be irregularities in test performance, and there might be irregularities in terms of our ability to actually execute on those tests. And so the advantage, as we've heard, and some of you have shared anecdotes of colleagues in Milan and elsewhere who are being asked to bronch these patients, in some cases multiple times a day, really, I have a very hard time with that right now. I think we will know much more about this, again, 6 months from now, 12 months from now, because even with the admonition to not default to bronchoscopy, we know that in a global pandemic, we will see thousands of patients who are bronched around the world for a variety of motivations, and I think we'll get more information from that. Treatment. Your colleagues who work in the critical care world, I think, are central, obviously, to this work, particularly absent yet a refined and evidence-driven approach to disease-modifying therapy, if you will. So the work around ventilatory support, intubation, non-invasive ventilation, and then peripherally, I'll just say a word about ECMO. There's a lot of questions about this, but there's something that's unique about, that I shared with you earlier, about the course of these infections that I think is instructive in terms of the approach to ventilatory support, and it's this. Remember I said earlier that for the patient at home who starts getting short of breath and comes into the hospital, there's I don't want to say an inevitability, but a predictability to the course. There's that pre-warning of, I'm more short of breath today than I was yesterday. That patient is progressing. Similarly, what seems to be seen is that among the hospitalized patients, those who are progressing with more and more respiratory compromise are going to a pathway to ultimate intubation. And so to that end, where there are concerns about cross-transmission, infection transmission around non-invasive ventilation, BiPAP and whatnot, it seems like there is very, very small set of these patients, if any, for whom early intervention with non-invasive ventilation is necessarily going to preempt intubation. And so some of your colleagues in Europe and elsewhere are saying, look, they're beginning a pathway to intubation. Just go ahead and intubate them sooner rather than later, because that's where you're going to end up. And if we can avoid the aerosolization and the other complications that come with the non-invasive mass ventilation, BiPAP, whatnot, then you may as well do so. And again, there's a lot to be said about that, because we are resource constrained, and if we're not now, we will be in the midst of the pandemic. I think we're getting a lot of information right now from the folks who are doing heroic work in northern Italy of trying to get a better sense of this. And because one of the things that they found, which has run counter to the experience in China, is the utility of ECMO. Both the literature from Wuhan, as well as our friends who are in Wuhan, let us know that they came to be very reliant on ECMO and saw large sets of patients who remained on extracorporeal support for extended period of times, leading in some cases to recovery, others not. What we're hearing early on with the tsunami that's hit Italy is that they haven't seen that same need or benefit, and what they're really seeing is just a lot of patients who are intubated. That's going to be the mainstay of therapy right now. There are happily and maybe serendipitously, additional interventions that I've outlined here that seem to be potentially of use in the management of these patients. So the one that's gotten the most credit and attention right now is remdesivir. So remdesivir is a nucleotide analog. It was developed specifically with an aim to treat Ebola and Marburg. So in many ways, remdesivir is set up for just this purpose of pandemic control. It's just a different pandemic. There have been some extremely favorable responses reported in China and U.S. And there was much made with the first severe U.S. case who was treated with remdesivir, who had this, Lazarus-like reaction of having risen up within a couple of days of receiving the antiviral therapy. It was enough and so dramatic that remdesivir has been applied in compassionate use format, and there are clinical trials underway. They've already been underway in China. There's as well Gilead-sponsored, NIH-funded trials as well that have finished. They have 60 U.S., I believe that one is just 60 U.S. sites. There may be international, so forgive me if I've got that wrong. In questions, folks can let me know if it's otherwise. But this seems like it could become the mainstay of therapy. That's the molecular structure that you see to the right. Trial and error has identified other tools, a handful of protease inhibitors developed for the treatment of HIV, including lopinavir, ritonavir, a combination branded under the name Kaletra, has been applied sometimes in combination with remdesivir in China. There's a phenomenon in infectious diseases whenever there's a new disease diagnosed, folks like to break out the chloroquine and Plaquenil, and there are some reports, again, primarily in China to date, about the use of those agents and perhaps seeing some response, but very hard to say because these patients, as they progress to that ICU stage, seem to be on this inevitable march forward. And so what we don't know about the application of any of these antimicrobial agents is when do we apply them, to whom do we apply them, and that's especially vital to understand because none of them, particularly as it relates to the remdesivir, are in strong supply or readily available. And then, of course, with the communications that came out of China, drugs like Kaletra, the lopinavir, ritonavir, are really in short supply, and there's been a run on those in the U.S. pharmaceutical market. One of the most interesting aspects of this, and our worlds in infectious disease, pulmonary, critical care, and others have long intersected around the role of anti-inflammatory immune modulatory agents in the treatment of severe infections like this. And depending on one's vintage on the call, you can recall the different agents that have been tried over the course of the years. The mainstay always being corticosteroids. Now, in the case of COVID-19, proceeding, including everything up to Actemra, an IL-6 inhibitor. The early experience with these, there's a recognition of a pronounced cytokine storm. In Italy now, what they're trying to do is sort through, as they're staring at these hundreds and hundreds of critically ill patients, of trying to delineate through assessment of an array of laboratory panels, looking at acute phase reactants, looking at other more specific signs to identify a subset of patients for whom directed therapy for the cytokine storm might be of benefit. The trade-off that we believe to happen in these circumstances, and hard yet to fully establish, but early reported with respect to COVID-19, is that these agents, particularly corticosteroids, are sort of accepted their administration to result in prolonged shedding of the virus. This is going to be, I would predict, really the area of most intense study and progress over the next 6 months or so as we continue to accumulate cases, because we come to a time when it will be willing to accept that prolonged viral shedding if indeed we can help folks weather either the acuity of the cytokine storm or the physiologic and architectural changes that might go on with progressive pulmonary involvement. I never want to leave off, even though I alluded to earlier, the last piece, which is, even though not well described yet, there's every reason to believe that with this infection, similar to all the other infections that we and our colleagues treat together, we're going to see additional super infections and whatnot, but that's something that's got to be managed. These are folks who are going to end up in your ICU. They're going to end up perhaps on an array of these directed antiviral therapies. They're going to be getting the supportive care. but they're also going to probably be getting broad spectrum antibacterial therapy as well, at least in the States. I think I can imagine relatively few folks would have the courage to draw down the antibacterial therapy, even in the face of a finding around the COVID. So again, I wish this could be more precise. I wish I could introduce a pathway for all of you, but again, at best, single institution case series, at worst, a case report or fixed opinion. But this is the state of the art right now, and if you find that unsettling, I think you're in the right place. You know, every great talk about this culminates in infection prevention, you know, my great love and passion. But let's go through and just look at where things stand right now in terms of infection prevention. I want to preface this by pointing out the challenge that we face both in the lay media for lay people, as well as for all of us when we looked at the really compelling imagery that was coming out of Wuhan. Because what do you see is even as I say those words and draw it from your memory, you're thinking about these heroic Chinese care teams in the bunny suits or space suits with a PAPR on, you know, in full gown and garb. And then the thing that you have to keep in mind as you look at that really relates to the state of the pandemic, or at that time, the epidemic that they were looking at. When you see those kinds of environments set up, they've moved into a time when they're cohorting patients, and those are individuals who are not moving in and out of patient rooms. They're immersed in an environment of exclusively taking care of COVID patients. And in that circumstance, that added apparatus is actually not driven by a higher level of infection prevention. It's actually so that they're going to leave that material on for a 6, 8, or 12-hour shift. And for any of you who did the training or took part in the management of folks with suspected Ebola or otherwise, this is an onerous task, but it's also not one that you're going to do with a yellow gown, a face shield falling off, gloves tearing off. So there is this unsettling disconnect when you go into the actual US CDC recommendations. So where we started with this was to say that for routine care, and that includes really anything that's not an aerosol generalizing procedure. In that case, the use of an N95 respirator or a PAPR is really the centerpiece in terms of the respiratory protection. That's accompanied by gowns and gloves. The gowns themselves can be of the more routine multi-drug resistant bacterial type, but are actually can be supplanted with fluid resistant if you're going to be doing a procedure, or the clinical care is one where there's apt to be body splashes to the body. Lastly is the important role of face shields. And in this, to be very explicit, this is a circumstance where one's prescription eyeglasses are not sufficient. So this either needs to be the screen over the mask or true goggles that are actually applied that are going to protect your eyes from side splash as well. That's been the mainstay of care for these suspected and known cases. Now in the US, we had a bit of a paradigm shift in the last several days. CDC, I guess it's about the days start running together, I think, for all of us, but CDC about 3 days ago issued a revision to their recommendations that said, in settings of shortages or uncertainty in the supply chain for protective equipment, mask and face shield should be acceptable in place of the N95 or PAPR. So in other words, keep everything else you saw up there, face shields, the gowns and gloves, but instead of an N95, that you could use a routine mask. Now, this is, again, not for aerosol generating procedures. So this is not you guys at the bedside doing a bronchoscopy. This is for routine care, such as I might give in the clinic if I were seeing one of these patients. The CDC went on to say that if the supply of masks and full equipment becomes available, you should revert to that. We might talk about this in the question and answer session, but fundamentally, this is an acknowledgement that the supply chain, at least in the US, is not robust for N95 respirators or PAPRs. The supply chain was largely rested in Asia, and as a consequence of that has been disrupted by the nature of the pandemic. And so to that end, right now for routine care, a lot of organizations, most organizations with whom I'm in contact with, are saying use the mask and surgical mask and face shield with the gowns and gloves as the core. What we are not compromising, nor is the CDC on, is for those of you who are involved in the conduct of high-risk procedures. In this case, anything that's aerosol generating. This includes not only bronchoscopy, very relevant to this, but a number of respiratory treatments that will induce coughing, and could include a number of other procedures that you all are involved with. In that case, we want to be uncompromising about the use of an N95 respirator or PAPR, the gowns and gloves, and face shields. This is the cornerstone. This goes, of course, with effective hand hygiene and a couple of other tools that I'll mention in a moment, but this is the PPE. It's uncompromising. This is essential for all of you for your protection, and it becomes doubly essential to make sure that we're being judicious in the appliance of those supplies so that we can make sure that folks engaged in these procedures, when they're done, are actually available to them. Infection prevention, I'll come back to in just a moment. This is an important in-house prevention. In-house, in this case, I mean in the healthcare facility. We want to make sure that we're not creating a closed environment like Wuhan, like that nursing home, where this infection might ping around. So you'll see more and more organizations, probably many of you on the call right now, limiting the meetings, taking up the use of virtual tools as we're doing tonight, limiting informal social gatherings. Can we have, instead of going for lunch together, can we go and pick up lunch, do the kind of order online, pick up lunch and bring it back to our desk or to our private area? At home, there's more to this that maybe we'll get into in question and answer, but this is the social distancing in many ways is the mainstay of infection prevention around this pandemic. You know, Michael and the folks asked me to just say a little bit about readiness at the organization, then want to get into questions. Basic hygiene, social distancing, I just said, that has to be there. The notion, when you hear the language on the news and elsewhere that we're moving from containment to mitigation, it's speaking that we're trying to avoid the idea of all of the sick patients that are going to happen in our city, in our region, in our country, coming in at once. You hear people more and more saying very casually, we need to flatten the epidemic curve, and it's true. We need to have these cases come in at a slower pace, and so doing things like what I mentioned in the hospital, and then at home, what the Illinois governor announced today, governors across the state, ideas of closing schools, ideas of limiting outside contacts. Keep in mind, because that can sound hyped up, but I think one important way to think about it is this. My kids coming home from school next week is not because they're at risk of getting sick at school. What they're at risk of is being a conduit of transmission within the community. That conduit of transmission, if allowed to proceed unchecked, eventually arrives at the doorstep of a 75-year-old who has hypertension, an 80-year-old who has COPD. Those are the folks who will continue and can get onto that march towards hospitalizations, complication, and death. And so there was a great post by one of the Italian clinicians who said, you know, when we ask you to not go to the cafes and bars and clubs, do that, you're not doing that for you. And in very provocative language, what he said was, the reason you don't go to those places is to prevent the extermination of our elderly. And again, that's deliberately provocative language, and particularly in that region of the world, but to again say that's the point of social distancing. You don't have to avoid the grocery store, to the mall or the movie theater because you're going to get sick, but because you might be the unwitting conduit that then when you go visit your uncle in the nursing home, that you become, again, without your knowledge, the transmission. In your organizations or in your practices, do you have the protocols and procedures of how you're going to manage these patients? Are they embedded into your workflows so that they become routine? This infection and this pandemic is going to be with us for months at least, and you need to be ready. Training and simulation. You can feel like it's too late, but there's a spotty nature to this pandemic. There's some of you on the phone who haven't had to think about this because there's been no cases in your state, and there's probably some of you maybe who are in Seattle or in Italy or Germany or elsewhere who are already living with this. While you can go through the training exercises to understand what it looks like to bring someone in, to swab them, to move them upstairs, it's critical. Maybe the most important thing we all struggle with is communication confidence. We cannot over communicate about this within our healthcare facilities. We will get some of our language wrong. We might have to move one step forward in a recommendation, then pull it back. But I think it's vitally important the most successful organizations have that trust and leadership in one another so we can get these answers. Supply chain and access to supplies. This is the one, you know, I usually say when people say, what keeps you up at night? not much keeps me up at night. But the prospect of exhausting the supply of PPE is really rather terrifying to me. And seeing the CDC go out and make recommendations for, in essence, a slightly less intense type of personal protective equipment is a signal that the CDC recognizes that our current consumption, and with the expected wave of patients to come, we won't have enough PPE in the United States. And that's something that, again, means we need to flatten this epidemic to give time for the producers in Asia and elsewhere to come back online and resupply us. And an important piece, and it was mentioned in my introduction, if you're hearing that your health system is standing up their incident command or emergency response team now, I'd be a little bit concerned. We've been blessed in this country with a multi-month head start. And setting up an incident command structure allows for, yes, we want to continue to serve our routine patients. They need our care. But at the same time, you need to have clear lines of authority and expectations so that decisions can be made around practice, policy, supply, and others that really gets the work done. What is it going to look like? I've been at this for a while and seen a lot of pandemics. This is bad. Again, I've set the stage. This is not the event that we go out and see the young people keeling over like the stories from the 1918 flu. But when you think about that nursing home in Kirkland, Washington, where I can't even keep up with the death count there. This is a single building, a single facility. It's a big facility. But when you're getting teens of death there, those are the kind of numbers that come from a fire or disaster in a building. They don't come from disease transmission. That's a signal that in the right environment, this disease is very, very, very serious. I think the response that we see now on the heels, not of, I don't want to be political, but not on the heels of a presidential speech or otherwise, but ironically in the US, by the change in sporting events and that the NBA canceled their season, certainly got people's attention. I tried to stop by the grocery store tonight to pick something up and I couldn't get in there. Some of that gets irrational, but it's a reminder that right now, this is an epidemic and a pandemic that may not affect each and every one of you in terms of your personal contacts and the folks that you interact with. But for those of you who are practicing, particularly in a hospital-based setting, read what you can from our colleagues in Italy. It's dramatic. The number of patients and the surge of patients coming to their ICUs, and what gets described as, well, I'm glad we cleared out our ICU this morning of our routine patients, because by tonight we had 8 patients admitted and ventilated with COVID. I know a couple of you, I'm not an alarmist about this stuff. This is very, very serious thing that's happening right now. And so the work that we do routinely, both as clinicians and also as ambassadors of fact in the community and with the people that know and respect us, is I think really very, very important. So I'm grateful for the chance to come and join you tonight. I've gone on for quite a long time, but I'm grateful that we've got plenty of time for questions now. And I really hope this has been useful. And I hope you understand that this is the best information we have right now, but please keep apprised of what's going on, keep aware of what's going on in your community and your institution, because the story is changing too rapidly to just do even one really good webinar and then set it aside for a long period of time. Again, thanks for having me tonight. And Michael, I guess I'll turn it back over to you.
Great. Thank you so much, Dr. Weber. I think that was you volunteering to come back and give us a weekly webinar as an update. But in any case, we certainly appreciate it. We have lots of questions here. So I'm just going to start really randomly, which is, how many times can you use an N95 mask? We've been saving N95s for the whole day of work. Can they be used for multiple days? How long is one of those good for? And should we be rationing those or what?
This is, if you think sometimes your listservs and your WhatsApp chat gets a little esoteric, you can imagine what the infection control ones look like. This has been a real focus of attention. Our routine position is to say that N95 mask, particularly in a setting in which you're dealing with droplet transmission, meaning larger than necessary for the aerosol protection you get with N95, means that around those patients, the outside of the mask is going to get covered with droplets, and so you run the risk of cross-contamination. There's also the hazard of how you're storing them. There can be degradation of the elastic band, as well as the seal that comes from the N95, especially when they're stored in plastic or jammed in the bottom of your drawer. Having said all that, watch this space. We're seeing more and more recommendations coming out for how you can do so safely. It'd be premature right now for me to give you a blanket recommendation about how long you could do so. What I will say is this. I think that the folks that are looking at it, first of all, get an understanding from your organization, your practice, be deliberate about your choice. It shouldn't be, again, as civic minded and humanitarian as you might be. It's not a good time for you to freelance the idea of, I'm going to shove this mask in my pocket and use it all day to try to help society. Take the recommendations that are coming on from your organization. They're looking for every means by which to stretch the use of these masks. So things like identifying that those that have expiration dates, they can be used beyond the expiration date. But in this case, you really need to consult with the local infection control program or the supply chain folks who will actually then be able to give you a little more informed opinion. Again, I got to apologize. It's a great question. I'd like to have a singular answer, but just the extreme of, yeah, as we run short on them, throwing them out every 2 minutes is probably going to feel too quick, but holding them on for a couple of days may be putting you or your other patients at risk.
Yeah, great question. And so along those same lines, a very similar question, can you put an N95 under a face mask?
Well played. This is, and so please see my answer to the last question. And that is to say that to that scenario in which those droplets might contaminate the outside of an N95, well, in that scenario, then if you had a surgical mask on over that, then you can dispose of the surgical mask. This gets into like really complicated, but really, again, very esoteric decision science, because now you will have consumed two products, one of which is clearly more valuable in shorter supply, but one of which is your backup in the case that the first one runs out. So I know we have, and a number of our peer institutions in Chicago have talked about this, and we said right now that feels like a hazardous proposal because you might be chewing through multiple supplies, but again, it's not a great answer now. I would not adopt that as my routine practice at present. But believe me, as we go forward over, and this is literally the issue with the supply chain on the mask is one that's unfolding in the window of 6 to 8 weeks. So we will know a lot more about this in the next, I would predict, 7 to 10 days. So again, I know it's a dodge, but I don't want to give you misleading information where we'll have more guidance in fairly short order.
Good, totally understand. All right, let's roll on. What is your sense of acquired immunity after recovery from infection?
I'm for it. I think that one of the things that'll get very interesting, we'll get a head start in that in China as well. It ends up playing in, Michael, to the question about what the next 8 months are going to look like, because is there a chance that the pandemic may subside somewhat in the summer? There is a chance. I wouldn't rely on it, but there is a chance. That being said, it would be naive to believe that even if that happens, that we're done. We would see another wave in the fall would be our reasonable expectation. Keep in mind, that's what happened in the 1918 series, where actually the second season, if you will, was even more aggressive than the first. That longer history is going to give us a lot more experience. So we have seen nothing about this virus that tells us that that gives us a clear disposition on what this will look like. I think we feel confident that there ought to be some degree of immune protection going forward. What I would caution against, and maybe it was behind the question, maybe not, but this notion of people, again, go back to what I said, they tested positive, they were better, and then they tested positive again. We have not established that those were reinfections. I suspect those were probably issues about still detecting either non-viable or some low-level shedding of RNA after recovery. So more to follow on that. See, these questions can be easy. There can be 100 of them, and I'll just say I don't know. So I hope that'll things along.
All right, let's talk a little bit about testing. Do we have a clearer sense of the sensitivity, specificity, negative and positive predictive value of the assay? And I assume that this is a question about RT-PCR, which is the only thing we're using to test now.
Yeah, and again, where there's a hazard, I acknowledge this in the talk, and it might be a little wonky, but because we don't have a true gold standard, it's a little hard to really be precise about the sensitivity and specificity. We do know that the sensitivity and specificity, we're getting a little loose with some of the language here, but depending on when it's tested relative to the course of the infection, evolves. Again, purists know that I'm now starting to conflate the positive and negative predictive value, but that's where I want to go anyway, because let's go back again to, we're going to test the whole NBA here in the US right now, the Basketball Association. We will find folks in that crowd who have felt sick and who will test positive and will have coronavirus. What do we do about the individual who has felt fine? He's having he had the best week in scoring that he's ever had his career, and he tests positive. I would submit to you from a positive and negative predictive value, because you're applying it to an extraordinarily low risk population, that's almost certainly a false positive. So I think as we go forward with more test availability in the US, I think we'll start to arrive at a pattern. We'll be able to answer those questions a little bit more completely. We'll have a better definition of what the gold standard is in terms of looking at this. And in some cases, historically, that's been around serology. So we may be able to go back retrospectively as we start collecting and banking serological specimens from some of these affected patients, that we'll be able to go back and look at these testing patterns over time and see if indeed the historically relevant convalescent titers that we always talk about in infectious diseases may hold the answer to unlocking some of the questions that you ask about the RT-PCR performance.
Great. So because we are the Society of Advanced Bronchoscopy, so I know we touched a little bit on this, but can you touch specifically about bronchoscopes, risk of cross-contamination? Is there a benefit to using a disposable scope, not a disposable scope, types of disinfectants?
Sure. Obviously a critical question, and again, consider the source now as an infection control guy. I'm always a little hesitant, and particularly in a setting like this, around the kind of quick bedside enzymatic dunk and whatnot. But when you get into even routine high-level disinfection, and here comes the provision that folks in my field always put in, right? High-level disinfection with a scope that doesn't have any compromise in integrity in terms of mechanical issues or surface issues. And when, sorry guys, the manufacturer's directions are followed, that gives me confidence about having avoided the risk of cross-contamination, even with this emerging pathogen. And I say that because while this emerging pathogen behaves very differently in humans in terms of the disease causes, as we've said over the last hour, it is more alike than it is dissimilar from the more routine coronaviruses that are terrorizing people on respiratory viral panel results now. And so to the extent that we've relied on those more routine methods around the treatment of the disinfectant treatment of the scopes, I feel confident. We haven't issued, nor has my professional society issued, any recommendations for added measures in terms of reprocessing of the scopes. But Michael, you also mentioned the disposable scopes. And let me just say a word about that. And you all know, obviously, the mechanics of this far better than I will. But to the extent that the use of the disposable scopes changes, I'll call it the team dynamics at the bedside. If you've committed to scoping one of these folks for a very good indication, because I don't want to forget that. If you don't need scope, then you don't need to worry about reprocessing them. But if you need to scope one of these patients, if using a disposable scope gives you the flexibility in terms of the number of staff in the room and the manipulations and others, then you start getting into a more complicated and maybe interesting decision, because in that circumstance, it may well be that the disposable scope gives you a little more latitude to reduce the risk of transmission to other folks in the room. Again, that's stuff that the Society for Advanced Bronchoscopy will know better than I do in terms of technique and that. But to the actual disinfection of the scope, the routine practice, disappointingly, I think, because everyone wants something more, sexy, is really ought to be adequate.
Okay. All right, so we've got a great question here from one of our international colleagues. So we want to build an inclusive spreadsheet for data collection, specifically for bronchoscopists, kind of without yet knowing what the research question is. But we want to start collecting this data, and we have the availability to do that through societies like, WABIP and things like that. So what do you think are the best items to collect globally? What do you think that would give us the most insight going forward when we're trying to figure out what the research question is?
That's a great question. I really appreciate it. And keeping in mind, so having led a lot of outbreak investigations, not of this scale, obviously, but a lot of outbreak investigations in my time. You have competing interests, right? Because there's certainly the effort of collecting additional data, but there's the idea of collecting too few data and basically falling in love with your a priori hypothesis in such a way that you will only find confirmatory data. At the same time, real life epidemiology is the place where association versus causation was first reported, because you can, in outbreak investigation, you connect enough data points and you analyze them without the right corrections, you're going to find some pretty compelling associations that have nothing to do with reality. So my advice is this: the data collection around this, even though you don't have a fixed hypothesis, you've got to have a domain that you're thinking about. You've got to have some framework. And I'll give you an example that came to me from a colleague in Milan, and I alluded to it indirectly in my remarks earlier, which was to say that they're really interested in identifying whether there are folks for whom distinctive features around the so-called cytokine storm might provide a target for intervention. And so for them, they're collecting additional samples and recording additional samples around acute phase reactants. They're looking at everything from immunoglobulin levels, ferritin, whatnot, to really try to identify, is there, in essence, imagine, if you will, and this isn't a big stretch, but the predictive tool, this isn't fancy AI that says, here's a set of intubated patients who benefit from, Actemra. This is the group of folks for whom corticosteroids is worth it, even at the expense of prolonged viral suppression. So your question is of a more broad nature, and I understand that, but I would encourage you, lest you drive yourself, your colleagues, or your fellow or your nurse crazy with collecting 100 variables, is start with something that you think you might be able to intervene upon. And I think that example from my colleague in Milan is a really good example of that.
Great. And we're seeing some data coming out about this question, but I think it would be great to comment on in the webinar, which is, how long does the virus live on surfaces? And maybe a follow-up question for that is, are the bleach wipes and things like that, are they adequate? Are there studies showing that there's still residual contamination after cleaning with some of these substances?
Yeah, and this can be extrapolated into a broader question. And I just saw it, and I actually looked at it as I was coming in here, and I didn't mark down, but Michael's right. There was just a piece that came out, and it was actually, I saw it was some sort of very dubious. We may not be talking about the same thing, Michael, but there's some very dubious pre-publication release, ironically from Princeton of all places, that was talking about survival of coronavirus on different surface types. We're going to learn a lot more about that and see, from our standpoint in the infection control world, no matter the pathogen, we always look to hard surfaces as being easier to clean and disinfect than soft surfaces, and all this kind of general rules. There's very little reason to believe that this is going to be an enduring pathogen on surface for days or weeks or anything dramatic like that. We do think about, it wasn't your question, but I want to offer just a reminder that with droplet spread, the room, cleaning a room afterwards, not only allows for cleaning of the surfaces, but also allowing any residual droplets or smaller droplet forms, which take longer to drop out of the environment, to do so. To the question, though, about the wipes themselves, the bleach wipes ought to be a reasonable option, again, when used on the right surfaces. I like to remind people, Michael, that the issue sometimes with those surface cleaners and that has less to do about the immaculate wipe down that you give of your iPhone, and more about the fact that your iPhone is not touching the patient. It's your hands and your body that are touching the patient. So the final common denominator between you and the patient and transmission to the patient is most often our hands. And so to that end, there's an important role to be played that if you're using the bleach wipes, if you're thinking enough to spend the time to wipe down your stethoscope, your other personal equipment, at least as much time ought to be spent on wiping down your hands, and particularly so in the environment, keeping in mind that when you're doffing the gowns and gloves afterwards, there's very few things you can do that will help get more bacterial and conceivably viral stuff on your hands than the taking off, especially without really meticulous technique of the gowns and gloves. So that's a good time to wash your hands again. And Purell
Yeah,
is the alcohol-based hand disinfectants are fine.
Yeah, there's some fantastic YouTube videos, some from Nebraska Biocontainment Unit on proper donning and doffing, and that's a very good point that you can do all these precautions, and then if you take something off wrong when you're all done, you could screw everything up. Another question is, so why is testing only offered in the ICU after a negative viral panel? Is it just Occam's razor or one explanation for one disease? Sounds counterintuitive if they have found autopsy cases with both influenza and coronavirus.
Thank you. And I'm glad I got a chance to draw this out, because I tried to, touch on it in the remarks, but I think a really important and insightful question. Remember, there's two questions embedded there, and perhaps from an American participant, which was, why are we only testing in the ICU? Keep in mind that if we were in a place that had ready and appropriate access to test, that wouldn't be true. We would be testing in many, many other environments. And we're now starting to see that through the commercial labs in the US. I know one of the other health systems in Chicago is starting one of these proverbial drive-through testing facilities. The merits of that are sort of another thing, but we just put that aside. But to your actual question about in essence, the risk of co-infection. It's being used right now in a setting where you are somewhat, in the US, somewhat limited into the availability of the dedicated COVID-19 test. And if you can find somebody who has influenza during flu season, which in most of the US we still very much are in flu season, that then it would be reasonable to conclude that that's the principal issue. I like to remind my fellows and others that, particularly when you work on healthcare-associated infections, which this is largely not, that Occam's razor quickly becomes Occam's lawnmower. And so, to that end, I think as time goes on, that shorthand around using a flu test as exculpatory in terms of COVID-19 is going to evolve. And I think there's some ID or critical care fellow somewhere who's going to soon publish the series of adult patients co-infected with influenza and COVID-19, at which point your point will be confirmed and you will have carried the day in terms of the lack of wisdom in that approach.
I saw some things recently, and again, it's hard to know when things pop up online. Has there been any issues with believing that there's more possibility of cross-contamination, or not cross-contamination, of co-infection rather, with RSV? I'm seeing some people saying that if you test positive for RSV, that they're still testing for COVID-19 because they've seen some cases of co-infection. Is that the case?
There might be local practices around that. I'm not as familiar with having encountered that yet, but that could change tomorrow. So I would go back to the previous question, which is to say that if you're under-resourced in terms of COVID-19 testing capacity, this is one way to maybe filter and enrich your population. But I think as time goes on, that's probably not going to bear out. And let's face it, as time goes on, we will have a more rapid and reliable test for COVID-19 that perhaps it'll be one of these multiplexed nucleic acid tests similar to the RVP. Good questions, but and rational thinking. So for those of you saying, wait, I don't get it. Why would testing positive for one do the other? You're right in the ultimate ideal world around this. For right now, though, the approach that I described in the presentation is really what's been at play.
Okay, great. Another question from some of our guests that work in Lung Cancer Foundation. So I work in a lung cancer foundation. Patients want to know specifically what their risks are. Do we have good data yet for young versus old, or people on TKI therapies or chemotherapies or immunotherapies?
Yeah, there's a few things to unpack from that. That the risk of disease increases with age, beginning at a range, 40 or higher. And I gave you the median numbers, which I know are the crudest estimate and not really giving you a great graphical sense of it. Median age of those who were hospitalized 60, median age of those who died of 80, median overall age lower, obviously, than both. And so as a result of that, right now, as we sit here on March 12th, age is our predominant risk factor. But now let's dig into the really great questions about the particular patients and community that you serve. Let me first disavow the group of the notion that when they say that people who are have complicating medical conditions are at risk, right? That was the language early in the U.S. part of the epidemic. These are folks with complicating medical conditions. It turns out these were not folks with metastatic renal cell cancer on top of lupus, on top of behavioral health issues. These were people who had complicated diseases you may have heard of, like hypertension or diabetes. So that envelope of patients with complicated medical complications were actually people who would barely even qualify to an insurance company as a pre-existing condition. It's almost what's pre-printed on the documents in a general medicine clinic: hypertension, diabetes, maybe COPD. So keep that in mind, that those folks themselves are already at higher risk. And now let's come back to the core of your question around the patients who with cancer, complicated cancer therapy, and I'll even extend it beyond to other diseases, disorders, and disciplines in which we administer immune suppressive medicines, immune modulatory. We just don't know yet. And I think if you're like a lot of my colleagues in that field who take care of these patients, there's really the question behind the question for some of them is, so forgive me if I'm trying to read your mind remotely here, is should I try to not administer the next round of this therapy? Should we skip, should this, in another discipline, should we skip the Remicade this month in order to protect them right now? We don't know the interplay yet. What I can tell you, which I think is important and level setting for a lot of folks, is we're not talking about a 2 or 3 week phenomenon here. So if I was right, and behind your question is, shall we defer the next round of treatment? That's only going to be successful, I would argue right now, if you feel like you can defer it for 3 months or 4 months. And generally speaking, with all of the disorders which I've alluded to in this last response, that's probably going to be hard to do. Again, I wish I knew more. The Chinese certainly deploy in places like Wuhan. We're using many of those therapies. Northern Italy for certain are. So I think we'll be getting a lot more information about this as we go forward. It's a good time to learn how to set all the alerts on whether PubMed, Google, or otherwise, so that you can be getting stuff that's really specific. It's the coronavirus and insert your own particular concern here and get that alert into your phone or to your email, because I think right now that's all going to change.
Yeah, so just following your aunt on Facebook is probably not going to cut it, is what you're trying to say.
It depends on who your aunt is, but yeah.
That's true. Okay, so back to the question of droplet versus aerosolized. For general contact, sounds like droplet precautions only, just a regular mask and face shield. So the question is would we consider, if we're seeing a patient in a room, even if it's a negative pressure room, a patient who's on BiPAP, high flow nasal cannula oxygen, CPAP, is that a situation where we should switch and be using an N95 because it's possibly aerosolizing it? And do we have data to back that up?
Yeah, I want to be really, I'm very glad that came up, because it's letting me know I did a poor job to the earlier part about the PPE. Aerosol generating procedures, unambiguously N95 or the PAPR. That's not a circumstance for a surgical mask. The aerosol generating procedures must be with an N95.
Okay.
Did I understand?
And so, yeah, no, that's right. I was trying to extend that to clearly a bronchoscopy, or intubation is an aerosolized procedure. But if a patient's just sitting there on maybe a high flow nasal cannula at 60 liters and 80% oxygen, or maybe on BiPAP, what is the consideration there?
So in that scenario, and this goes to the notion that we said, and that the experience is sort of showing, saying, if you're heading to that inevitability of intubation, just go ahead and do so. In those scenarios, with the information we have right now, including high flow nasal cannula, I would actually, those would be folks that I would select out to use the N95. So again, health system or practice or hospital, you're allocating, what are the circumstances for mask versus respirator? That would be a scenario where I would use respirator.
Okay. So I kind of talked to you a little bit about this before the webinar, but a question's come up. Is it true that we're expecting 700,000, 1 million deaths or more in the U.S.?
Maybe.
Easy question.
There's so many moving parts right now. And again, I went back to some of the mortality estimates where, I think in terms of sensitivity testing, what if that assumption, I called it 1 to 3% mortality, and just for argument, we'll say, what if 2 is kind of the summary statistic for that? What if we're off by an order of magnitude? Well, certainly if it's 20, not 2, then this is going to be the kind of societal changing thing for which we fear. What if it is tenfold less? What if it's 0.2? That still is substantially more than influenza. I think my expectation, apart from the numbers, is over the next 18 months, from what we've seen, probably more, I'm going to describe it in terms of the United States population. I don't mean to alienate any of our international users, just helpful for me with the numbers. In the U.S. population, I think we should expect more than half of Americans will be exposed to and experience this virus. I'm using that language because for many of them, perhaps children, they may never even notice that it's happened to them. When we start, the trouble, Michael, is when we start talking about those numbers, you're not even talking about clinical illness anymore. So projecting out the 1%, 2%, or 0.2% becomes really, really hard to do. Let me at least say this. Let me put brackets around it. The first is for all those folks who are saying flu kills 35,000 Americans I shouldn't mock that language, but flu kills all these people every year. I believe very firmly, and I think the experience over the last bit of time shows that this will be much more substantial than an average flu year. And whether it is 10 times that number and it's 300 or 400,000 Americans, or if it's 100 times that and a million, 3, 4 million, those are the numbers that I think are kind of resonating for me when I tweak what are the bounds of realism of proportion of people impacted, proportion of mortality, proportion of people get tested. I look in that range of being, roughly, as Tony Fauci said, about at least tenfold worse than influenza. What becomes important to this is that going to happen over 6 months, or is that going to happen over 2 years? And that makes all the difference in the world. And if this were the last question, I would say that's why you will do a ton in managing this pandemic through your work as expert clinicians and proceduralists, but you will do even more for it by returning to your community, your family and friends, and saying, no, this is real. We should not all get together. Or no, we should do this as a conference call and not get into the same room. That's something that we do. And again, think about that message from Italy, because you may not be in the high risk groups, but there are people out there that they're generally going to be your elders, our aunts and uncles, or mothers, those who still have our grandparents. They're the ones whose lives we're determining with decisions we make around social distancing.
Great. Is another follow-up question about the N95 to kind of clarify. So are we using the N95 just in suspected cases, regular cancer cases? When we're doing bronchoscopy specifically, if we're doing a regular cancer case, are we fine using the regular surgical mask, or should we now use N95 even in those cases, or is that a waste of an N95 mask?
It's a tough one. For right now, until the supply chain is restored, I would not adopt this for the routine use in those cases. And particularly, again, and you deliberately chose a circumstance in which you said this was for a cancer diagnosis. So this is not someone with a acute respiratory infection or syndrome. If you change it and say there's a guy in the ICU who we think it's probably XYZ bacterial infection, in that circumstance, if you're bronching for an infectious diagnosis, then I absolutely would.
All right, last 2 questions and then we'll let everybody go. Are ARBs a reasonable salvage therapy if it's tolerated by their blood pressure?
Maybe, yeah. And actually, I didn't call them out on the slide. So one of the for the spike protein on the coronaviruses actually does interact with the epitope there, and so ARBs may play a role. That's something that's being studied. I'm not aware yet of a large-scale clinical trial, but I didn't look into that before. And ironically, as I was sitting here, I got a message from our chief pharmacologist, so I could just text him right now and find out. But I think as we go through, as they did in China, as they are in Italy right now, we've got a bunch of patients. Let's try what we can use, not just to try to study, but to see what works. The experience with the ARBs will grow out of anecdotes, and hopefully will be consolidated slightly in case series. And then I expect as we go through with the pandemic, it'll be studied a little bit more. To the point that you made with respect to the hypotension as a risk, one could argue, and I say this, with some caution given the hazards around these drugs in general, there would be very little downside for someone who is, been intubated for a week, and you want to try to see if you can alter the course of it. I think that an ARB is reasonable.
Great. And so the last question is just a very general question. Obviously, you can take this into your closing moments, and it's actually just kind of an interesting question. There's a rep who's on the call who's non-clinical professional, and he says other than staying out of facilities, what can they do to help, or what can we all do to help each other in this situation going forward?
I think it's the point I wanted to emphasize earlier. It's this is a credible threat, as it were, but this is not a panic-inducing moment. I mean, I know, again, from my experience at the grocery store tonight, but it's keeping in mind that, again, that the language and the piece to say there's a segment of our population and in your community who's at risk. And the things you can do to contribute are to abide by and then endorse the kinds of things you're hearing about, that, we're not going to do the dinner party with the 6 couples tonight. We're not going to go to the crowded restaurant. We're going to, maybe have a smaller get together at home with 4 of us who, we can trust and know, because that kind of information and practice, look, in the US, this gets into a lot of politics, a lot of angst about things, but facts really do matter. And right now, it ought to be empowering that the things we can do together to interrupt the flow and slow down the flow and transmission of this virus will spread out the epidemic. And that gives time for all of us who have practices in the hospital and critical care, because we'd all rather see a steady stream of 3 or 4 COVID patients in our ICU every day for the next year than to see 45 of them showing up next week. And that's really essential. So, and I'm grateful that question came from a non-clinical person, because the fact of the matter is that's something that we can all be empowered to do. And anyone who has a thought leader, an opinion leader, and a presence in their community with their friends, I would put that on us, not just as an option of what to do, but a responsibility of what to do.
Yeah, that's a fantastic answer, and I think that's a good one to close on. Once again, we'd really love to thank you. This was an absolutely fantastic and insightful webinar. We are going to be posting this on our website. You can see the website address there, sabronchoscopy.org. Give us about 24 hours to get it up there. It will be free. Usually our webinars are for members only. We're going to make this one free and open access to everybody. We're also in the process of administering a survey to bronchoscopists and physicians who are out there kind of on the front lines with these cases. If you'll look on the screen, take a moment to fill out the survey. We'll send this to your email, and we'd love to understand different practices and approaches that people are going through right now across the world. We are an international society. That's why it doesn't say American in our name, and we want to represent everybody. So again, thank you very much to Dr. Weber, and thank you all. Have a good night and be safe.
Good night. Thank you.